Today we're going to talk about respiratory care in patients with ALS. The idea is to understand why they need respiratory care, learn about the therapies and how you can support your loved ones better, and how you can kind of like guide their decision making. When we're breathing, we use our muscles, and it's essentially like a pump. And so we use our diaphragm and muscles in the chest to make sure that we're activating them, and that causes the air to go in the lung. And then we breathe out. When the muscles are weak, then that process of bringing the air in also gets weak. And that causes them to have shallow breathing. And the shallow breathing is uncomfortable, so it causes shortness of breath. And it can also cause to lower oxygen and higher CO2 levels. It starts initially maybe with activity. Some of the issues I tend to see is that many individuals with ALS start slowing down as they get weaker, so they may not notice the limitation. It's also affecting their breathing. And it's also very noticeable for some, and majority of them, to when they lay down. And so when you lay down, this muscle that is here, the diaphragm, that's the one that is highlighted in red, it doesn't get the benefit of gravity. Gravity helps it kind of stay down. So even if it's weak, then the gravity keeping it down helps the lungs stay bigger. But when it's weak, and also some other muscles that are supporting bone structures are weaker, and there may be a little bit of bending of the spine and like encroaching of the size of the lungs, then gravity becomes like their worst enemy, right? Because it makes the belly contents push up and kind of affect the breathing muscle and the diaphragm even more. And it also causes the upper airway muscles to get more easy to collapse, and the tongue to go down and block the airway more. So it is harder to bring the air in, and there is more resistance to bringing the air in. And so for many of our loved ones, the shortness of breath may start when they're laying down, and they may start adjusting without even realizing. They may start sleeping on a recliner or using several pillows to sleep. And so if you notice that, or if they're mentioning it to you, it's maybe a sign of the respiratory weakness that is a result of the process of ALS. And then laying down upright as we do activities. And activities doesn't mean running a marathon. It could be brushing the teeth. It could be, they're struggling to get dressed. And they may start limiting some of the activities that they enjoy on their day-to-day life. Gardening, going to the mall, grocery shopping, even like folding clothes can start like limiting their activities because of the shortness of breath. So pay attention to those signs. You may also notice that their voice is getting weaker. So they may start talking, and their voice like volume starts to fade away as they take breaths in between. You may notice that they use some of their neck muscles to kind of help them get the air in, and that they are breathing shallower but faster. And they may struggle with cough. And that's something that I ask in every visit. Like, have you noticed a weaker cough? And it's something that I find that unless it's actively asked, it may go unnoticed. But once I ask, then, they may realize it's like, oh yes, it's been harder to get this phlegm that accumulates in the back of my throat out. Or you may start noticing that they're coughing as they're eating. Swallowing, talking, and breathing are very complex functions that require a lot of muscle coordination, and we do it constantly without even thinking about it. But in our loved ones with ALS, that becomes very difficult. And so because the muscles in the throat also get either weak or spastic, they get like thick, like stiff. And so coordinating the talking and the swallowing or turning the head and eating becomes trickier, and the food may be going down into the lungs, which prompts cough. Now, the cough, for us to cough effectively, we need to take a deep breath in and then activate muscles to get that air super fast out so that we can essentially like use projectile style, like getting out of secretions or foreign bodies from the airways. Our loved ones that are weak have difficulty with that activation. And so the cough being weak can increase risk of aspiration and pneumonias too. So they may have had these frequent infections, frequent admissions to the hospital because of pneumonia that may be coming from that mucus just getting stuck in the lungs, and then it kind of like acts like food for bacteria. And then ultimately, you may also notice that they're struggling to keep the head up. A lot of the necks and the muscles can a lot of the muscles in the neck can get actually affected. And so then you start, like the head is very heavy and it's very hard for patients to keep that up. And if they're struggling with the neck strength, then the swallowing and the breathing can also be affected because it's affecting their throat positioning. And so those are all reasons that lead to a really careful support of their respiratory function. When should we start therapy? So let's say we're seeing our loved one, whether we're starting to notice rapid shallow breathing, or we're starting to notice that the voice is getting weaker, or they're expressing shortness of breath, or they started sleeping propped up. Or maybe, they actually haven't expressed any symptoms of like respiratory symptoms. They haven't noticed any weak cough, or they haven't had any shortness of breath that is noticeable to them. It could be that they're really also at the same time not moving as much, right? So it may be hard to elicit with a symptom that the breathing is weak. And so because of that, we actually monitor the breathing objectively with pulmonary function tests. So we measure the air that they're able to bring in and push out of the lungs. And we also measure like the amount of strength that they have for the muscles of breathing in and the muscles when they're breathing out. And we do that with pulmonary function testing. The pulmonary function testing we want to monitor for most people every 3 to 4 months. And it is not a comfortable test. And it's something that, I know that some of my patients with ALS really are not looking forward to, but it's very important to do because that's what's going to give us the numbers that can allow us to make that decision. It's like, okay, now we should start therapy. On top of the pulmonary function testing, we can add oxygen monitoring for overnight during sleep because sometimes the pulmonary function testing is weak, but we don't meet that cutoff that the guidelines insurance are requiring to get approval for starting home respiratory support therapy. But, again, we want to monitor for more risks are like objectively so that we can start this therapy earlier. And usually shallow breathing may start initially during sleep because our muscles relax even more, so it can get accentuated. So pulmonary function testing, let's say, has not met those thresholds that would allow us to start therapy at home. Then we can do an oxygen test overnight and see if we're capturing the low oxygen that can be sustained for more than 5 minutes overnight, or we can check if the CO2 in the blood is going up. And obviously every time we do a symptom review. In this picture, you can see one of our patients doing the pulmonary function testing that I was referring to, that some of my patients dread. They have to take a very deep breath in and then breathe out fast. You see that the nose is kind of like pinched so that we can measure the air that is coming in and out of the lungs. And we're also measuring strength. And you notice that we're doing that same measurement when they're laying down, because we have to capture the weakness of the muscles, and we want to start that therapy as early as possible. So this is the other testing. The nice thing about this is that you can start this at home. It's a test that you can help them do at home, or they can do themselves. It's an oxygen probe for most parts that will then give us a tracing. It's a medical device, so it's like a high definition pulse oximeter, and it helps us kind of do that tracing to monitor whether there's drops of oxygen. And you know, they may happen also in certain parts of the night, for example, like in REM sleep when the muscles relax even more. And we can even measure CO2 levels overnight as well to see if that shallow breathing is causing that CO2 to creep up. And so let's say we've monitored the testing and we're finally at that point where we met the thresholds and we're recommending starting therapy. And, you know, our loved one is on board with starting the therapy, knowing that we start therapy earlier and it will help with quality of life. It will help with shortness of breath and decreasing hospital admissions and prolonging life. So there are essentially like 3 areas that we will tackle. The first one, and I think the most obvious one, is helping them take deeper breaths. So it's ventilation. That's what that's called. And it's a mechanical fix for a mechanical problem. So that's non-invasive ventilation because it's done through a mask. And we're going to talk a little bit about the devices that can be used to provide that non-invasive ventilation. The other are devices for secretion management. So like all the mucus that is produced by the lungs every day in a normal way to keep the lungs nice and open, or because of, you know, you had a cold and you had extra mucus, then we have kind of like interventions that tackle those and making sure that the lungs are clear from secretions that are getting stuck there, or talking about, you know, the cough being more effective and kind of like saliva also accumulated in like the mouth. And the other area is like techniques that they can do at home to kind of help with the breathing that may not necessarily involve a device, but more like exercises or more portable like devices that they can use to help kind of keep the lungs nice and open and clear of secretions. So we're going to start with the non-invasive ventilation part, which is kind of like that mechanical support. We can deliver this therapy via essentially 2 groups of devices. One is your respiratory assist device. That's a mouthful to say. It's like your regular BiPAP. And that looks almost like a CPAP from outside and maybe a different color, but it has a heated humidification. So that means like it has a water chamber attached to it. It has to be connected to power. So it's not battery operated. And so for most part, it will be on a bedside table connected to power. And then you'll have the hose and the mask. And so we make sure that the mask is not only comfortable, because that's huge, that's very important, but also effective. So we need to make sure that it seals well and that is what your loved one needs. And they may think that first they want a full mask, is this going to cover better? And then after trial and error, figure that they do better with a nose mask or a nasal pillow mask. And so some of it is kind of a discussion between the healthcare team and your loved ones and you as helpers at home as of what's going to work better for them. But at the same time, you know, after you try it, we just reevaluate and see if we need to change the mask. So that's your kind of like BiPAP, regular BiPAP. It also is like a rent to own, like your insurance or the insurances in general rent these devices, and over 13 months it gets paid, and then it's owned by pay the patient or your loved one at that point. And if they, need supplies, they'll continue to pay for those. So those are some advantages of the smaller machines. It also allows me to look at the data, and we can also make changes to that machine remotely if needed, based on what we're discussing or we're seeing for effectiveness or for comfort. The other group of devices are devices that are ventilators. And so these devices are also BiPAP. They also provide a pressure when you breathe in and a pressure when you breathe out, and that helps move more air per breath. But they have some extra features. So one of them is battery operation. So they can be used during the day. They can be used if they're gardening outside, if they're playing at the casino, like one of my patients love to do, if they're just sitting in the living room, having some visitors, then they can have it next to them, and it doesn't, or even like flying on a plane, they can have their machine support them. So it doesn't need to be plugged to the wall. The other is it has alarms because it is considered kind of more a life-sustaining device. And it has some programs. So you can have up to 4 programs in some of them. Like you have a BiPAP with the mask, the traditional one that is doing the ventilation. And you may have also something called sip ventilation, which is like a puffer. You take a sip of air pressure, and that can help them relieve the shortness of breath without having to put a full mask on. And also can help them take a deep breath for coughing, or kind of help them not feel so short breath when they're eating. So then they can eat, sip, and continue eating, or even have longer conversations because they're able to take a sip and then keep the voice at a good strength level so that they're heard. They are rental only, so that means that the patient or your loved one never really owns the machine. They're rented along with the respiratory therapy support that comes with it, and then they usually have separate water humidifiers and separate modems. So it is kind of like a bigger machinery. It's like the BiPAP, the water chamber, and the modem. There is also a misconception where patients and family members, your loved ones, will be concerned that the machines are like breathing for them. They don't want to be dependent of these machines, or that is weakening the muscles because they're not using it. And that's actually not the case. They are supporting the breathing, and they actually allow for maybe using less of the energy of the body to use extra muscles to get enough air in. And, it may help with decreasing that energy expenditure on breathing and the weight loss that results from that, because it's almost like exercising extra every day to breathe. So that's something to keep in mind. In regards to the mask, I think the mask is something that is very important to everyone. I think, even like there's advertisement out there for obstructive sleep apnea therapy that kind of shows the mask in a very negative way. The mask is whatever mask that works for them that they like. And it may take several trials to get that under control, or choose the one that they really like and works well. But that's okay. That's what we're here for. So there is the pillows, the nasal, and the full face mask we talked about. We tried, we evaluate, and then we need to change. We change those. But there is many options in the market. This is one of my patients, for example. He loved his full face mask. It was causing some pain here on his head. And so they added some padding for helping with support, and that worked well. So that was, his wife's idea, and she was his caregiver at home, and it worked really well. And he used it actually for a long time, 24/7. I did provide this mouthpiece for him, which he also liked to use for kind of taking breaks from the mask and helping him with visitors, which he loved. And then we had the nasal mask, which is a different kind of therapy. It's called high flow nasal therapy. Some of the ventilators can provide this. It's essentially airflow at up to 60 liters per minute, but usually between 20 or 30. And it's heated and humidified. And it can be used in some patients if they're really struggling to tolerate the mask. No therapy is for everyone. So let's say, you saw the symptoms, they met the criteria based on testing. We started the non-invasive ventilation. We tried different masks, different pressures and comfort settings, from, when they get the breath to how fast they get it, and they're still struggling. Many of them is because of stiffness of the throats of the muscles. So it's not like it's their fault, right? It's a limitation of the therapies that we have. Then high flow nasal therapy can provide some support by giving some pressure in the back of the throat and kind of like washing out some of the CO2 that just stays in the upper airway, and heating and humidifying the secretions that can help the patient kind of clear them more effectively. So it doesn't really ventilate or provides deeper breaths, but it can help if they're not tolerating that ventilation. And it's kind of like via these methods, and it's already built in some of the ventilators we use for our loved ones at home. Then, once we started the therapy, I referred quite a bit of monitoring. So we monitor for symptoms for sure. Are you feeling better? Do you like it? Is the machine giving you a breath when you want one? Is the pressurization time enough? Like, do you want a faster breath? Do you want a slower breath? And we can adjust all of that. But we also adjust for effectiveness. So for example, we have this data where we show the usage, the mask fit is fitting great. We see that the pressures when they breathe in and breathe out, that's the lighter blue and the darker blue. And then we see the amount of air per breath and their respiratory rate. So I saw that maybe it was not at the target that we wanted. And so we increased kind of like that pressure support that they get. And that resulted in bigger breaths and a slower respiratory rate, which is a more effective therapy. And the patient loved it. So this is like a win-win situation. And those are some of the things that we'll do. Let's say again, we've tried, even the high flow nasal cannula is not working well. The negative pressure ventilator is essentially kind of came from the iron lung in the polio pandemic. It's an external device that, we can fit to the patient's chest, and it has a machine and it will pull to kind of open up the chest and kind of release to let it go. And it can also act as a secretion management device. And so for certain patients, this may be another option that we can consider. So that's part of the BiPAP machine. To be able to use the BiPAP effectively and in general, one of the kind of symptoms that can be very bothersome to them and that can be embarrassing to some patients and can interfere with the therapy is the increased salivation. And actually, it's not so much that they're making more saliva, is that they cannot swallow it. So it kind of stays in the mouth. So it's difficult. Please reach out and advocate for them because we can try these medications first as a non-invasive first step, but we can also try procedures like ligation of the duct that causes that saliva to go from the gland to the mouth, or things like Botox injection, which will decrease the amount of saliva that goes into the mouth, or even radiation therapy that will kind of suppress that. And so that's an important part of the management along with the BiPAP machines. And then we can also use the cough assist machines, which we'll talk a little bit about, to help kind of clear the secretions. That's huge. By now, most of us have heard or read about non-invasive ventilation or BiPAP or the masks. That's a very vital, important part of the management in individuals with ALS. But when I mention, I'm the machine lady and I'm going to talk about the second machine that I think they may benefit from, then most people have not heard about cough assist devices. Cough assist is essentially like a bathroom plunger. It will deliver a high pressure and then deliver a very negative pressure. So positive, negative, essentially doing that vacuum suction of the mucus in the lungs and helping them augment the cough. So it helps in both ways. It helps open the lungs and keeping them nice and open, and it helps them clear the mucus from the lungs and kind of like making sure that the lungs are not getting stuck with mucus they cannot cough out. And so we prescribe these devices. Most of them, they're automated. They do 5 cycles. And then I usually kind of have a third machine that I prescribe. Most of my patients love it, which is the suction machine. That allows them to kind of manage any saliva or mucus that comes out, which is that suction and a suction canister. So it's very convenient. And it helps kind of pull from the back of the throat too, if they're having difficulty kind of clearing it from the back of the throat to the mouth. And so the BiPAPs and the cough assist machines are the cough assist can also be battery operated, but it can be cumbersome to kind of move it around. Most of the times they have it at home, or if they get admitted to the hospital for any reason, to keep doing this treatment 3 times a day before meals, whether they have cough or not, or mucus or not, because it's a preventative measure. It keeps the lungs open and decreases the secretions down. But we can also provide them with devices like this that are manually operated. It's an ambu bag. It's essentially like that bag that she's squeezing in this picture with her legs and allow them to get a deeper breath and cough or talk or get some relief of dyspnea if they're out and about. The other one is also called sip breathing, or stacking the breath. And what they do is we ask them to take 5 small breaths together, and then they can push their belly, or you as a healthcare, as a family caregiver can help them kind of push to have a more effective cough out. So they'll do and then someone pushes, or they push on the belly as they're coughing out to kind of help have a stronger cough, even if they're not have access to the cough assist device at that time. So those are techniques like breath stacking that can help as well. You may be familiar with vests. Vests are used in a lot of our patients that need respiratory assist devices at home, but it usually is more helpful for patients that have quite a bit of secretions, but a strong cough. For my weaker patients, it's it shakes the mucus, but then they may still struggle to get it out of the lungs. And so it usually is not my first to go therapy for secretion management, although I do use it on a case-to-case. We have to talk about invasive ventilation too. It's a topic that we must discuss with our loved ones and as a family, with friends or the healthcare team early on, because many of our patients can be supported with non-invasive ventilation only. There are certain cases, let's say, there are difficulties with the throat, it's really not functioning, not allowing them to breathe in or out. There is a lot of difficulty with secretions, or they really need 24/7 support, and the non-invasive or mask ventilation is not being enough. Now, when we have the situations when someone wants invasive ventilation for home, we need to make sure that they know they'll need to train family members or friends, home caregivers, 24/7 that can manage their respiratory devices and help each other if one is absent for any reason. The ALS clinics and the ALS United group, they're all great resources, us as pulmonologists, to kind of answer any questions that may come up around, whether this could be the best decision for your loved one and what it implies for the caregivers at home. Some of the myths is like, our patients cannot eat or talk when they're invasively ventilated. And the fact is that we can do pretty comprehensive evaluations. This is one of our speech and swallow therapists kind of doing that evaluation and scoping our patient with a tracheostomy to see if it's safe for them to eat or if there is some risk of aspiration, like are they willing to take that risk so that they can have that like wonderful ice cream they love and crave. And then we have patients that have the neck drop that we talked about because we have the neck is very weak. And so if that's the case, supporting the neck with devices, it's huge. I've learned a lot from family members and from my patients over the years. And so this is one of them where the wife kind of got this device for support because it was the summer, the other ones were too hot. And like they decided that they wanted to give this a try. It caused a little bit of pain initially, so they padded the chest device, and that worked out well for them. But our occupational therapists and physical therapists have a lot of information that can help to keep that neck nice and up, because that's also important to optimize the breathing for our individuals with ALS. I want to kind of highlight the support of the ALS United team, and I'm very thankful for them for putting these educational programs together and for supporting you guys, because it makes such a huge difference when our patients have their friends and family support. So thank you all for doing that too.